Good morning guys. Today I am here to explain you about the surgical anatomy of the atrioventricular valves, which basically includes the mitral and the tricuspid valves. So we already know the basic anatomy of the heart. This is the heart. It includes SVC, IVC. There are 4 chambers: RA, RV, LA and LV. The outflow tract, in which the RA, RV drains into the pulmonary artery and the LA, LV drains into aorta. In between each of these 2 chambers or the 2 parts, there are valves. So basically, separating the chambers and the great arteries, there are 4 valves in the heart. So there are 4 valves in the heart separating each chamber. The 2 atrioventricular valves, that is mitral and tricuspid, and the 2 arterial valves, that is aortic and pulmonary. The atrioventricular valves are highly asymmetrical valves, as you can see from this figure. In different from the arterial valves, those are 3 symmetrical. The subvalvular apparatus is quite regularly made in the atrioventricular valves, and as opposed to that, in the in the aortic and pulmonary valve, there are rarely any subvalvular apparatus. Mainly there are 3 cusps which are joined. Also, all the valves are joined to each other by a fibrous body. It is the part of the fibrous skeleton of the heart which joins all the valves together, and it is one of the toughest structure of the heart. So as we can see in this figure, the atrioventricular and the arterial valves are in the same plane, but actually it is not in the same plane in the heart. This is the modified figure. As the anatomy, we can see that the atrioventricular and the arterial valves are in different planes from each other. No 2 valves are in the same plane and in the same dimension of each other. So here we can see there is a tricuspid valve, here we can see there is a mitral valve, this is the aortic valve, and this is the pulmonary valve. The mitral, tricuspid and aortic valve are joined together by a fibrous structure, which we already said before is the fibrous body of the heart. So now we will talk more about the mitral valve. The name mitral valve is owing to the resemblance to the planar view of the bishop's mitre, which we see the headband of the bishop. The annulus and the shape of the mitral valve is this biplanar concavo-convex shape. According to some books, it is said that mitral valve is not just a valvular structure, but the anatomy of the LA and LV plays a very important role in the functioning of the mitral valve, which we will see later on. There are various parts of the mitral valve which helps in the normal functioning of the mitral valve, which includes mainly the valve leaflets, the subvalvular apparatus, aortomitral curtain, endocardium, arterial myocardium, and the ventricular myocardium, which we will see each and every part in detail. The annulus of the mitral valve. The shape of the mitral valve, annulus of the mitral valve, changes throughout the cardiac cycle. During diastole, it is grossly circular, and systole, the AP diameter decreases more than the transverse diameter, hence it becomes D-shaped. And there is reduction of almost 25 to 30% during the systole of the heart, the reduction of the annulus and the valvular surface area. As we can see here, it is a 3D planar structure, the annulus of the mitral valve. It is concavo-convex, that is typically of the saddle shape of the mitral valve. So there are 2 low points and the 2 highest points. The lowest 2 points are located at the fibrous trigone, and the highest 2 points are located on the anterior and posterior annulus. The plane of the mitral valve makes an angle of 120 with the aortic valve. It is having a continuity with the aortic valve, which we have seen previously. It is because of the fibrous trigone, and the AML continues with the mitral valve. The plane of the mitral valve makes 120 degree with the plane of aortic annulus, which facilitates the inflow of the chamber in the left ventricle. If this angle, 120 degree angle, decreases, then the inflow is superimposed on the outflow tract, facilitating abnormal systolic motion, that is SAM, of the anterior leaflets, which is explained by, suppose this angle is reduced, the AML, that is this line, goes more towards the LVOT, and it obstructs the outflow tract of the LV. So it flutters and decreases the flow from LV into aorta. So it is called systolic anterior motion of anterior mitral leaflet, which obstructs the LVOT. So which structures are close to the annulus of the mitral valve? Rather than reading it out, we will see the pictures and it is more explainable. The structures is firstly the circumflex artery, the coronary sinus, the bundle of His, and the NCC and LCC of the aortic cusp. This is the surgical anatomy of the mitral valve as seen from the surgeon's view. This is the aorta, this is the LA which is open below the Sondergaard's groove, this is the mitral valve. These are the two papillary muscles, this is the anterior mitral leaflet, this is the posterior mitral leaflet. And in order to see it very easily, we can see it is drawn in such a way that the structures posterior or the structures deep to the mitral valve is also seen here. This is the circumflex artery, LCX. This is the coronary sinus, and similarly this is the AV node and the central fibrous body from which it is attached to the mitral, which is attached between the mitral, tricuspid and aorta. This is a simpler diagram of the structure surrounding the mitral valve. This is the AML, this is the PML, which are divided into three parts, P1, P2, P3 from lateral to medial. Similarly, A1, A2, A3 to its corresponding units by the scallops. This is the circumflex artery which goes just beyond the P1 and P2, and this is the coronary sinus which surrounds the P2 and P3. Similarly, there is a AV node which is present around something around the right trigone, which is a part of fibrous body, and here we can see the aortic valve with the left coronary cusp and non-coronary cusp, which is corresponding to the mitral anterior leaflet of the mitral valve, which is thus said to be the aorto-mitral continuity. So basically, as we have seen before, there are two leaflets of the mitral valve, anterior and the posterior. The anterior leaflet is also called the aortic leaflet and the posterior leaflet is also called the mural leaflet. But strictly speaking, it is more of anterior superior and posterior inferior leaflet because the axis is not in the one plane. It is somewhat of a oblique kind of axis. As we can see in the diagram, the anterior leaflet occupies 1/3 of the total annulus of the mitral valve. It is just occupying 1/3 of the total annulus, and the posterior leaflet occupies 2/3 of the total annulus of the mitral valve. But the surface area of anterior leaflet seems more because from the anteroposterior point of view, the anterior leaflet occupies more than 2/3 of the total mitral valve area, and the posterior leaflet occupies less than 1/3 of the total area of the mitral valve. The anterior leaflet is related to the aortomitral curtain, as we have seen before, related to the LCC and NCC, and the posterior leaflet is related to the circumflex artery towards the P1 and P2 and coronary sinus towards P2 and P3. As we can see here, the anterior mitral leaflet is more of a trapezoidal kind of shape, and the posterior mitral leaflet is sort of a band. There are two parts of the AML, the rough zone and the smooth zone. The rough zone is the area which is coapting. This is called the coaptation. This is anterior mitral leaflet, posterior mitral leaflet, and the leaflet area of the leaflet which touches each other during the systole when the mitral valve is closed is called the coapting area. The area which touches each other produces friction, and hence the coapting area becomes the rough zone, and the superior area which is towards the LA side becomes the smooth zone. As we have already seen, the proximal arterial zone, that is the smooth zone, is regular, thin and translucent, while the distal rough zone has numerous chordae attached to it and is demarcated by easily demarcation by a transverse line. The posterior mitral leaflet has two fissures in it, which divides into three scallops, that is P1, P2 and P3 from lateral to medial, as we have seen in the figure before. Amongst the scallops, the P2 is the largest and the P1 is the smallest. The purpose for these scallops P1, P2 and P3 to develop is to facilitate the total opening of the mitral valve. As it the band like PML opens completely and the AML goes towards the anterior side. So the mitral valve completely opens and it induces the flow from the left atrium to left ventricle. Now the commissures. So what do you mean by the commissures? The area of the leaflet which joins anterior mitral leaflet and posterior, that is AML and PML, is called the commissures. So basically there are two leaflets and two commissures, anterolateral and the posteromedial. It provides continuity between the anterior and the posterior leaflet at the coaptation surface which is adjacent to the anterior and the posterior leaflet. The junction between AML and PML does not reach the annulus, but it forms a Y-shaped line of coaptation, as we have seen. It forms a Y-shaped line at the area of coaptation. It does not extend to the annulus. If we assume this as the pink annulus, it does not extend to the annulus. The line of coaptation is parallel to the PML and it is approximately 15 mm from the anterior part of the annulus and 5 to 6 mm from the posterior annulus. It is evident from the figure that the line of coaptation, that means this line, is parallel to the line of attachment of PML to the annulus. As we can see, this area is significantly larger than this. It is almost 2 to 3 times more than the PML. So this is almost 10 to 15 mm. This is just 5 to 6 mm. And the midline length of coaptation is approximately 7 to 9 mm. So there are different terminologies which we need to know regarding the coaptation, that is coaptation height, coaptation length, coaptation depth, which is seen in this figure. Suppose this is the AML and this is the PML. Similarly in this is the AML, this is the PML. This is a schematic diagram when there is systole. So both the leaflets are coapting each other, and this is during the diastole when the leaflets are away from each other. So when the leaflets are coapting, the length AML is complete AML, as we can see here. Whole length of AML which we see in the figure before is complete, but it divides into two parts, rough zone and smooth zone. Smooth zone is this one, rough zone is this one after the coaptation line. So coaptation distance is when the heart is in systole, the distance between the line of coaptation to the annulus from the AML and from the PML is called the coaptation distance of AML and coaptation distance of PML. And the other terminology is coaptation length. Coaptation length is the length of the leaflet after the point of coaptation. So this is the point of coaptation. The length of AML beyond that is called the coaptation length of AML, and the point of PML beyond the point of coaptation is called the coaptation length of PML. Another terminology is coaptation depth. Coaptation depth is the depth of the point of coaptation below the level of mitral annulus. If we assume this as the level of mitral annulus, the depth between this point is called the coaptation depth. During the systole, there are chordae attached to the lower side of the leaflets which pull the leaflets towards the LV side. Hence, there is a suction force which develops. So the coaptation line indebts into the LV. So this distance is called the coaptation depth. This is the coaptation distance and this is the coaptation length. And when the heart is in diastole, the whole of the coaptation line disappears because there is no coaptation point developed. So all these measurements are just for systole. In diastole there are only two diameters, the AP diameter and the total length of the leaflet. We cannot measure the coaptation distance, depth and length in diastole because of obvious reasons. So now the suspension system. The suspension system mainly consists of two parts, papillary muscles and the chordae tendineae. So what are papillary muscles and the chordae, which we will see in detail before. The function of basically papillary muscle and chordae tendineae is to facilitate the opening of leaflets during diastole and prevent the upward displacement of leaflet above the plane of annulus. To prevent upward displacement at the time of systole above the plane of annulus. This is the plane of annulus. This lowering of the point of coaptation, that is the coaptation depth, is due to the subvalvular apparatus, or we will say the suspension system. So firstly, the papillary muscles. The papillary muscles, there are two basically group of papillary muscles which is called the posteromedial and the anterolateral group. Basically the morphologically there are five types of papillary muscles. First is, there are basically five types of papillary muscle. First is the large bulky papillary muscle with multiple head of chordae attached to it, but there is single head of papillary muscle. The second is there are multiple heads of papillary muscle with chordae attached to each of it. Thirdly is the small head of papillary muscle with small amount of chordae attached to it. Fourth is the arcade like papillary muscle and chordae tendineae attached to it. And fifth is there is no obvious papillary muscle, but the chordae are directly attached to the ventricular wall itself. So these are the classification of papillary muscles. The anterior papillary muscle, that is the anterolateral, are basically of type 1 and type 3. That is, there is a big papillary muscle with chordae attached to it, or there is a small papillary muscle with chordae attached to it. So anterior papillary muscle, that is the anterolateral papillary muscle, are basically of type 1 and type 3 configuration. That is, there is a large head with chordae attached to it, or there is a small head with chordae attached to it. While the posteromedial papillary muscle is of type 2. That is, there are multiple heads with chordae attached to it. Papillary muscle are implanted on the muscular wall of the left ventricle at the junction of 1/3 from the apex and 2/3 from the base of annulus. And the anterolateral is implanted at the junction of septum and the posterior wall, either directly or indirectly with several muscular bands. Now the vascularity of papillary muscle. It is of utmost importance because it has clinical implications when there is ischemia, that is a severe MR or caudal rupture, papillary muscle rupture. Anterolateral papillary muscle is vascularized by anterior descending artery by its diagonal branches, as well as the marginal artery from the circumflex vessels. So it is highly vascularized. While the posterior medial papillary muscle has only RCA supplying blood to it. So it is more prone to develop ischemic changes. So when we see acute MR in a patient of papillary muscle rupture or acute MI, it is mostly because of the rupture of posteromedial papillary muscle rather than the anterolateral papillary muscle, because of its dual vascular supply. And the vascular pattern in the papillary muscle is, suppose there is a papillary muscle, there is a single vessel transversing through it and there are branches arising from it. There are 1 or 2 central arteries with branches dividing from it. So this is the LAD, this is the anterolateral papillary muscle, and this is the LCX. So it has got blood supply from the diagonal as well as from the OM, while the posteromedial papillary muscle only has from the blood supply from the RCA, hence its blood supply is compromised. So chordae tendineae. These are the structures extending from the papillary muscle to the leaflet. Suppose this is the leaflet of mitral valve, these are the papillary muscle arising from the LV. So there are basically 3 pair of chordae tendineae, the primary, secondary and the tertiary or the basal. The basal or the tertiary is present only in the PML, not in the AML. The primary leaflets are attached at one end to the papillary muscle and second end to the apex of the mitral leaflet. So the edge of the mitral leaflet, it provides the strength, and if it is torn, then the mitral leaflet becomes flail. So instead of going to the down LV side during the systole, it goes to the LA side, and hence the mitral regurgitation occurs from here. The secondary papillary muscle, it is attached to the the chordae tendineae extends from the papillary muscle to the leaflets. Basically there are 3 types of papillary muscle: basal, intermediary and marginal. Marginal is also called the primary, intermediary is called the secondary, and the basal is called the tertiary. The marginal is present attached to at the one side to the papillary muscle and second side to the edge of the leaflet. The intermediary or secondary attached to the belly of the leaflet, and the tertiary or the basal is attached to the base of or near the annulus. It is not necessary that basically the tertiary chordae tendineae is attached to the papillary muscle. At times it is extending from the wall of the LV directly to the base of the leaflet from here. The tertiary papillary muscle or the basal papillary muscle is present only in the PML, not in the AML. The AML only consists of 2 types of papillary muscle, marginal and the intermediary. There are different terminologies given in different papers, and terminology has evolved in the years. But basically, it is easier to remember these three, and this is the simplest diagram for knowing the type of type of chordae tendineae and its extensions. So basically, there are different types of chordae. So these are the commissural chordae. It arises from the AML, the PML, and goes directly into the commissures. It forms a Y-shaped pattern. Y-shaped pattern at the commissure, and it is attached to both the AML as well as the PML. Hence, it is called the commissural chordae. The other chordae is paracommissural chordae, which accompanies from the papillary muscle to the leaflets and goes parallel to the commissural chordae. The other important chordae is the main chordae, which at times it attaches to the papillary muscle and the edge of the chordae. It prevents the flailing of the leaflet, and it is one of the strongest chordae. And to assess it and to help it, there are other paramedian chordae, which helps and increase the strength of the main chordae at the time of systole. Here also we can see what we have seen previously, that there are atrial surface and the coaptation surface, the smooth zone and the rough zone, the chordae attached to it. Also similar diagram is given here, the Y-shaped chordae, that is the commissural chordae. Now the movement of the mitral leaflets. It can be seen precisely by echo in M mode. The normal M mode. Now the movement of mitral leaflets. It can be precisely seen by echo in M mode. The normal M mode examination, there is M pattern in AML and W pattern in PML. It is easier if we see this in diagram. So, at the starting of the cardiac cycle, there is passive flow beginning from the LA to LV. As we can see here, there is a passive flow beginning from LA to LV, which opens the mitral valve leaflets. So if we put a cursor in the M mode, which we see the motion, that is the M mode, M stands for motion. If we see the motion of AML, PML at the level of this line, we see there are two parallel lines, and the AML, PML is coapting. Now the flow, as it goes from LA to LV, the distance between the leaflet increases. Hence we can see the AML going upwards and PML going downwards in M mode of echo. Now the vortices of the blood, which goes from LA to LV, curls around, and again it makes the AML and PML come towards each other. So as we see in the echo, the graph goes downwards for AML as well as the PML. So the sort of coaptation or the length between the AML PML, distance between them decreases. Now again, when the atrial contraction ensues, that is the last part of systole, that is the last part of diastole, that is the presystolic phase, there is the atrial contraction. So the AML PML again opens, and the residual blood from the LA goes to LV, and which leads to the increase in the distance between aortic and mitral leaflets. So this M pattern which we get in AML and this W pattern in PML. The first bulge in the M is because of the passive flow from LA to LV, and the second bulge is because of the flow from LA to LV during systole of the atria. Now we will talk something about the tricuspid valve. The anatomy of mitral and tricuspid valve is similar in some fashions, but the main difference is it is between the right atrium and right ventricle as opposed to the left atrium and left ventricle of mitral valve, and there are three leaflets in the tricuspid valve, hence the name tricuspid. The components are similar, like the leaflet, the annulus, the chordae tendineae, papillary muscle. Also the RA and RV forms a part of the tricuspid valve complex. Now the leaflets. Basically there are three leaflets, like AML and PML. In the mitral leaflets there are STL, ATL and PTL, that is septal tricuspid, anterior tricuspid and posterior tricuspid leaflet. Amongst the mitral, there is AML is bigger than the PML. Here the ATL is bigger than STL is bigger than PTL. So anterior leaflet is the largest leaflet, followed by septal leaflet, followed by posterior leaflet. The septal leaflet is called septal because it is attached to the base of IVS. It does not corresponding to atrial septum. it corresponds to the ventricular septum, while the anterior and the posterior leaflet, it corresponds to the and is attached to the free wall of RV, which we will see in the next slide. At the time of contraction, similar to the mitral valve, the tricuspid valve annulus also contracts, and the reduction is not uniform. The reduction is directly related to the size. So firstly, the septal leaflet, as it is attached to the IVS, it does not decrease in length much. As opposed to that, the free wall decreases in length, so the ATL and PTL, that is the anterior and the posterior leaflet, decreases in size. So one needs to understand this figure. It is having the crux of the anatomy of the tricuspid valve and the RA also. These are the structures related to the tricuspid valve which needs to be taken care of and not to be injured during any of the surgery of the tricuspid valve. So as we can see in this picture, this is the SVC, this is the IVC, this is the cannula given in SVC and it is snugged, cannula in the IVC and it is snugged, hence we can see there is a bloodless field in the RA. This is the aorta, you have opened the RA, these are the retractors, these are the RV. So what are the two things? This is the tricuspid valve, this is the coronary sinus. This is a valve which is protecting the coronary sinus, another valve which is protecting the IVC. Eustachian valve and Thibetian valves. These are the two valves. This is the fossa ovalis. It is the site of ostium secundum ESD. Now there is a triangle which we see in the RA, which corresponds to tendon of Todaro. Tendon of Todaro is a fibrous structure which corresponds to the junction of Eustachian and Thibetian valve as it goes towards the septal leaflet, and it is parallel to it, attachment of septal leaflet. The other side of the triangle is formed by the attachment of septal leaflet to the annulus, and the third side is the coronary sinus. The apex of this triangle corresponds to the location of the AV node. This has to be taken care of while taking the sutures around the tricuspid valve in case of tricuspid repair or replacement. So as we can see here, the tricuspid valve has three leaflets, anterior, posterior and the septal. The anterior leaflet is the largest one, followed by the septal and the posterior leaflet. This is a diagrammatic representation, hence we cannot see the actual sizes of the leaflet, but this is the actual photo. Here we can see this is the anterior leaflet, this is the septal leaflet and this is the posterior leaflet. So it is obvious the anterior leaflet seems the largest one, followed by septal and the posterior leaflet. This is the coronary sinus, this is the tendon of Todaro, this is the attachment of septal leaflet to the annulus. So this becomes a triangle of Koch. So its apex corresponds to the AV node. This whitish structure corresponds to the AV node. It has to be taken care of at the time of surgery. As we can see here, there are three leaflets, anterior followed by septal and the posterior in the sizes. This is the coronary sinus, septal leaflet is attached to the base of IVS and anterior and posterior leaflet is attached to the RV free wall. When there is RV dysfunction and dilatation of RV, the IVS region doesn't expand, whereas the free wall region expands and it leads to the dilatation of RV. So it directly from the expansion goes from the anteroseptal commissure to the anteroposterior commissure. Maximum length is measured at this point. So with time it increases, and hence the tricuspid repair technique in which we de-size or decrease the size of the tricuspid valve area, the most important part is to take care of the free wall of RV rather than the septal area. Also there is a AV node sort of sitting over here, so we have to take care of suturing. So the rings which are present or the de Vega suturing which we do for the tricuspid repair is done from mainly from the posteroseptal commissure to the anteroseptal commissure, avoiding the AV node, and there is no need for the suturing over the septal commissures. So as we can see here, previously we have seen that there is a fibrous body which is between the mitral valve, tricuspid valve and the aortic valve. The AV node here around we can imagine coronary sinus. This is the AV node tricuspid valve. So it goes in the fibrous body and divides and becomes one bundle of His, from where it supplies to the IVS and the ventricular system. The subvalvular apparatus is similar to the mitral valve. There are two papillary muscles in the mitral valve, but as there are three leaflets here, three commissures, hence three papillary muscles in the tricuspid valve. It is named accordingly: anterolateral, posteromedial, and the septal or infundibular or conal. At times it is also called the strongest infundibular papillary muscle. Beside that, it is called the muscle of Lanzisi. There is another distinct muscular band which is called the moderator band. It was previously said that the moderator band moderates the size of the RV as it is connected from the RV free wall to the IVS, and it it prevents the RV from dilatation, but it has proved wrong eventually, but the name persists, the moderator band. This is the diagrammatic representation. Here we see the tricuspid leaflets, the anterior papillary muscle, the posterior papillary muscle, the septal or the medial papillary muscle, that is muscle of Lanzisi. From that, this is the moderator band, which is attached at one end to the RV free wall and attached at the second end to the tubercular septomarginalis, that is the part of the IVS. We will see that in detail when there is a lecture of IVS itself. Also, the attachment point of the moderator band to the RV free wall is the point of origin of anterior papillary muscle. These are the points of anatomical consistency. It is always there. Moderator band is to be seen, the site of attachment of anterior papillary muscle is to be seen. This is the anatomical picture. This is the tricuspid valve, the outflow, inflow, outflow of the RV, anterolateral papillary muscle, posteromedial papillary muscle. This band, we can see only half of this moderator band because the RV free wall has been completely removed. And this is the septotubercular marginalis, and this is the conal papillary muscle, that is the muscle of Lanzisi. So three papillary muscles, three leaflets, outflow tract, and the moderator band. So this is the anatomy of the tricuspid valve. It has to be known in such a way that we prevent the complications during the surgery of tricuspid valve, and also at the time of VSD. This is to be known, and how the conduction bundle and conduction system passes through these membranes of the IVS. Thank you very much.